Hello everyone. Today we're going to talk about proteinuria. This is something that we will often come across as we assess patients. So I thought it would be a good idea for us to go through this. The objectives are to revise the basics of how the kidneys will normally handle protein and then to develop an approach to a child who comes in with proteinuria. So the kidneys act as a sieve for many different substances, including proteins that are found in blood, and they prevent the movement of these various substances into the urine. So let's look at these various components one by one. We'll start with the blood. So blood, among other things, contains various types of proteins, and these proteins can be separated using techniques such as electrophoresis. Here is a drawing of what an actual electrophoresis strip would look like. So under condition of pH 8.6, we would get separation of serum proteins such that negatively charged proteins such as albumin would be closer to the positive electrode, and followed by alpha globulins, beta globulins, and on the far right, we would get our gamma globulins. So these are the various types of proteins that are normally found in blood, and these are the proteins that are prevented from accessing the urine by the next component, which we're going to look at. This next component is the filtration barrier. The filtration barrier is made up of the fenestrated endothelial cell, the glomerular basement membrane, and the podocytes. So these three together make up the filtration barrier, and they act as a hindrance for various substances gaining access to the ultrafiltrate in Bowmans space. These substances include proteins. So what are some of the factors that will determine how easily a molecule gains access from blood into Bowman's space? Among these factors are things like the size. So generally speaking, proteins less than 20 kilodaltons will be freely filtered, whereas those above 70 kilodaltons will virtually be unable to cross into Bowman's space. And then of course we have the charge. We know that the endothelial membrane has glycoproteins that are negatively charged and tend to repel negatively charged molecules, proteins, and so therefore that would limit the movement of negatively charged proteins into Bowman's space. And then let's look at what the urine, or rather the ultrafiltrate, now looks like after having traversed this filtration barrier. So we still have immunoglobulin G and immunoglobulin A, but immunoglobulin D is unable to cross the filtration barrier. We still have some alpha and beta globulins. Among these proteins are antitrypsin, 1-alpha antitrypsin, transferrin, haptoglobulins, insulin. We are also able to see that the ultrafiltrate will contain light chains and then albumin. So under normal circumstances, these proteins largely do not appear in the final urine. And the reason is because the proximal cells take these proteins up and either hydrolyze them into their constituent amino acids, or will facilitate the movement of the whole molecule back into the blood. So among the mechanisms that are responsible for this in the proximal tubule include the binding of these various proteins to receptors such as megalin and cubilin that are found on the luminal membrane of endothelial cells. And then once they bind to these receptors, the receptor becomes incorporated into an endosome, and then within the endosome, due to changes in the chemical composition of the endosomes, changes, for example, in pH, in chloride content, we see a dissociation of the protein from its receptor, and then the protein gets moved to lysosomes where it is hydrolyzed, whereas the receptor is recycled back to the surface of the cell. So that in the final urine, we now get a situation where albumin provides about 30% of the protein in the final urine. Immunoglobulins consist of only 5 to 10%. Immunoglobulin A, only 3%. And then you find about 5% of the protein in urine being light chains. Then we have this new protein that has appeared, the uromodulin. Now, this uromodulin is not present in plasma. It's produced by the epithelial cells of the thick ascending loop of Henle, and it's the major protein that's found in urine. Function is not exactly very clear, but it seems to play a role in the innate immune system as it's able to bind bacteria. It also prevents crystallization of calcium. Just a note here on the types of protein in the urine. So we can actually calculate the ratio of immunoglobulins to low molecular weight proteins such as albumin or transferrin to kind of comment on how selective the filtration barrier is. So if we get a ratio that is less than 0.1 or 10%, that would be known as a highly selective proteinuria, meaning that the filtration barrier is still quite effective and is limiting the sizes of the molecules or proteins that are being filtered through. And then once that ratio goes above 0.5, then we would say that the filtration barrier is poorly selective, and we have a poorly selective pattern. Other people prefer to use what is known as the selectivity index, where they use this formula where they get the urinary immunoglobulin G multiplied by the serum transferrin levels, and then divide that by the serum immunoglobulin G level multiplied by the urinary transferrin level. And the index that they get would tell them whether they have a selective proteinuria if the index is less than 0.1, or moderately selective if the index is between 0.1, 1 and 0.2, or unselective, it's greater than 2.1. So both of these parameters, just as I said earlier, tell us how porous the glomerulus is to protein. And generally, if you have conditions like minimal change disease, for example, so less severe damage to the glomerulus, we would see a more selective proteinuria as compared to conditions like, for example, FSG or more extensive damage to the glomerulus. We would then begin to see an unselective pattern of proteinuria. So that can be used in that way. We certainly don't use it in routine clinical practice. So since we're talking about proteinuria, for us to have a meaningful conversation, I think we need to look back at how one would measure urinary proteinuria. How does one quantify proteinuria? So that takes us back to the discussion of urinalysis, where we had talked about the dipstick. And just to remind ourselves that commonly we use the dipstick. This is a semi-quantitative means of measuring proteinuria. Significant results would be anything 1+ and greater, which would mean that one needs a quantitative test. But again, there's a caveat to using this dipstick proteinuria. Firstly, the fact that the dipstick does not measure excretion rates of protein, it measures concentration. So in a patient who is polyuric, it may underestimate their level of proteinuria, or conversely, in a patient with concentrated urine, it may in fact overestimate their level of proteinuria, And you can go back to the talk we had on urinalysis to just look at some of the factors that may actually give you a false positive reading for proteinuria on dipstick. Things like extremely alkaline urine, certain chemical substances, detergents in the urine. But essentially, one way of quantifying proteinuria would be by use of dipstick. The range is from trace to 4+. Then we can also measure urinary protein by quantitative methods, where we get the total protein that's present in urine, and we can do this firstly by calculating the protein excretion rate. This entails a 24-hour collection of urine, and then calculating the concentration of the protein that's present in that specimen of urine, then multiplying it by the volume. So normally in children, the excretion rate of urine is less than 100 milligrams per meter squared per day, but because of the immature function of the tubular of the tubules, excretion rates tend to be higher in neonates and infants, such that in neonates, excretion rates of up to 300 milligrams per meter squared per day may be considered normal. So at the bottom there, I've put in these very nice articles that give us details of the various excretion rates at different age groups. But certainly, the excretion rate, just like in adults, is expected to be less than 150 milligrams per day. Now, we all know that it's quite challenging to do a 24-hour urine collection. The younger the child, I mean, we don't necessarily want to start placing catheters into children's bladders just in order for us to have a complete collection. So therefore, an alternative method, which is very popular in pediatrics, is to carry out the protein creatinine ratio. So the protein creatinine ratio is just based on the fact that the daily excretion of creatinine based on age, since we're in pediatrics, is known. And so therefore, if you know the daily creatinine excretion and you have a sample with a predetermined protein creatinine ratio, you can calculate the excretion rate for the patient. So using a protein creatinine ratio, a reading of 0.2 grams per grams in children over 2 years, just like in adults, is considered normal, whereas for children under 2 years, it's slightly higher. So 0.5 grams per gram would be considered as normal. Please note that because creatinine is determined by muscle mass, these calculations are not valid in children with malnutrition. And at the bottom here, remember I said that if you know what the excretion rate for creatinine is, and you know what a patient's protein creatinine ratio, you can estimate what their daily protein excretion rate is. So this is a formula. They used regression methods to come up with a formula, can give you the total amount of protein being excreted per day. Thus far, we've concentrated on total protein in urine, but one can also quantify the amount of albumin that is found in urine. So using a 24-hour urine collection, normal excretion rates for albumin are less than 30 milligrams per day. When we get excretion rates of between 30 and 300, that is called microalbuminuria. This is not detectable using conventional dipsticks. Once the excretion of albumin is greater than 300 milligrams per day, that becomes detectable by dipstick, conventional dipstick, and is called clinical or macroalbuminuria. Obviously, we're in pediatrics, so 24-hour urine collections are a bit of a challenge, particularly in younger age groups. So one would prefer to do an albumin-creatinine ratio. And using this ratio, a normal albumin ratio, creatinine ratio would be considered as anything less than 30 milligrams per gram. Microalbuminuria would include ratios of between 30 to 299 milligrams per gram, and then ratios between 300 and 2 grams would be considered as macroalbuminuria, and anything above 2,000 milligrams per gram or 2 grams per gram would be considered as nephrotic range proteinuria. So the reason I added this slide was just to say that there's a lot of evidence that has linked poorer outcomes, poorer cardiovascular outcomes, and poor renal outcomes with the presence of even microalbuminuria, but this is in adults. The evidence is not so robust in children. So we can classify proteinuria into 3 types based on the normal physiology that we just talked about. So where you have dysfunction of the glomerulus, so increased permeability of that glomerular filtration barrier, you would end up with what is known as a glomerular proteinuria pattern. Largely, the type of protein that would be found in this kind of a patient would consist of albumin as compared to tubular proteinuria. And tubular proteinuria occurs because the tubular cells are dysfunctional for whatever reason, and because of that, they are unable to take up the low molecular proteins that are passed into the Bowmans space in the ultrafiltrate, and therefore, as a result, the low molecular weight proteins such as transferrin, retinobinding protein, beta-2 microglobulin begin to appear in greater quantities in the urine. And then finally, we have the third type of proteinuria pattern, which is known as overproduction or overflow proteinuria. And this happens because of increased production of proteins, as would occur, for example, in multiple myeloma or in rhabdomyolysis, where we have spillage of myoglobin into the plasma, and that would eventually end up in the urine, or in situations where you have intravascular hemolysis, hemoglobin appears in the urine, or in cases of pancreatitis, proteins such as amylase would end up because of their being overproduced in the urine. Using electrophoresis, everything that we've talked about has sort of different patterns. So one can use electrophoresis to sort of differentiate between these 3 different types of proteinuria. So on top there is a graph showing us the normal distribution of serum proteins. So on the far right, we can see albumin. That little peak is albumin, followed by alpha globulins, beta globulins, and then on the tail end, gamma globulins. So in urine, after filtration, we can see that there's a drop in that peak on the right. That's on the second chart. There's a drop in the peak in albumin because it's filtered by an effective glomerular filtration barrier. So in glomerular proteinuria, that's the third chart, we can see that again, that peak, which represents albumin, is back. And because of a defective glomerular filtration barrier, we get the albumin, more albumin appearing in the urine. And that is what is responsible for that albumin peak. In tubular proteinuria, there's an increase in low molecular weight proteins. So our beta globulins, a few of the alpha globulins as well. So we can see a peak in the region of the beta globulins. Then finally, in overflow proteinuria, This is meant to represent a patient with multiple myeloma. We have that single peak, which represents the light chains. So this diagram is from Schreier's diseases of the kidney. I thought it would be nice to just illustrate how the different types of proteinuria end up with different patterns on electrophoresis. Then in terms of causes of proteinuria, we can look at them as those that are transient, meaning they go away after some time, and persistent. So there's what is known as orthostatic proteinuria. So a patient who gets up from a lying down position will suddenly get protein appearing in the urine. Patients that have fever, patients that have engaged in vigorous exercise, patients with heart failure, patients receiving infusions of drugs such as epinephrine may have transient proteinuria. Then there are other patients that have persistent proteinuria due to glomerular defects, whether these may be genetic, like for genetic causes of nephrotic syndrome, or patients with Alport syndrome, or inflammatory causes of glomerular damage, so vasculitic disorders, patients with HUS, all of those can end up with persistent proteinuria. And then we have patients with tubular proteinuria, where you have dysfunction of the tubular cells, so they are unable to take up all that protein that is found in Bowmans space and in the proximal tubule. So conditions such as interstitial nephritis or congenital conditions like Fanconi's, Dent's disease, and so on. Other conditions include dysplasia of the kidney, reflux. Patients with reflux may have persistent proteinuria, or patients that have urinary tract infection may also present with persistent proteinuria. Our approach to a patient who has proteinuria will be that once our dipstick has anything greater than trace or more, we would want to do a thorough history, trying to evaluate for any danger signs. We would want to find out drug history from the patient, any associated skin abnormalities, joint abnormalities, family history of renal disease, history of deafness in the family or other family members. We would want to find out any history of masses, any history of bladder symptoms, and so on. And then we would go on to do a thorough examination of the patient, assess the growth of the patient, look for obvious dysmorphisms. We would examine the skin of the patient, looking for features of vasculitis, any other obvious skin abnormalities, examine the joints. We would examine the abdomen, any abdominal masses. We would want to do the blood pressure of the patient, make sure that's normal, make sure that we examine for edema on the patient. So obviously, if any of these abnormalities I've mentioned are present, this is a patient who should immediately be further evaluated by doing investigations that we're going to talk about in a little while. But if the patient has no obvious abnormalities, then we would let them go home and then repeat the dipstick on at least 2 other occasions. And if they have significantly abnormal urine dipstick findings, that is 1+ or greater, on 2 out of the 3 occasions that we've done the dipstick, we would then go on and do a formal quantification of the urine, meaning that we would do an albumin creatinine ratio or a protein creatinine ratio, or in older children, do a 24-hour urine collection and quantify the daily excretion of protein in the patient. And then we would then go on and do investigations like microscopy culture sensitivity. We'll do a full blood count, check the renal function, so look at electrolytes, urea, creatinine, the albumin, we would do imaging of the kidney, ureter, bladder, check for dysplasia, hydronephrosis. We do an autoimmune screen looking at the ANA, the C3, C4, infectious screen, things like hepatitis B, HIV, RVT. And then a few of these patients, depending on the findings, may then be referred on to nephrology for a renal biopsy. Treatment is directed at the primary cause of the problem. We would target the primary cause, and there may be a role for the use of AC inhibitors to control the proteinuria. These are some of the references that are used. Thank you so much for listening.